evidence-based guidelines for kerato-refractive lenticular extraction surgery. I would like to thank Dr. Shaima El-Basuni who helped me in the preparation of this presentation. The aim of this study is to develop an evidence-based guidelines for kerato-refractive lenticular extraction surgery. And this evidence-based guidelines was based on the WHO guidebook and based again on the evidence that was drawn from 8 literature databases, 5 clinical guideline databases, and 2 academic organizations to study 250,710 papers had been published in the kerato-lenticular refractive surgery to put these guidelines with the help of the Delphi consensus for 44 global experts in refractive surgery, corneal diseases, retinal diseases, glaucoma, and optometry. And I have the honor to be one of these authors, and this paper is in proof in December 2024 to be published in next few months in the Ophthalmology Journal. These guidelines are covering 3 main domains: the preoperative screening and indications for kerato-refractive lenticular surgery, the intraoperative quality control, surgical planning and techniques, and the prevention and treatment of KLEX-related complications. So the first domain is the indications. There were put 38 recommendations. The preoperative screening of keratoconus, selection of surgical options and surgical plans is mandatory. And the first recommendation is keratoconus is contraindicated for corneal refractive surgery. The second, the surgery can preserve some biomechanical properties postoperatively. The third, the thickness of the removed corneal tissue is directly affects the corneal biomechanical strength. The lower the thickness removed, the less the biomechanical affection. And the corneal biomechanical properties influence the surgical predictability of the refractive outcomes. The second domain is the surgical planning and techniques. The safe ranges of corneal thickness are mandatory to be known for the surgeon. The calculation of the percentage of tissue alteration, or the PTA, that we use in the regular LASIK surgery could not be applied in the refractive lenticular extraction surgery, as we cannot put PTA of 40% or more, because this definitely will lead to ectasia. So the range of corneal thickness should be not less than 280 microns of residual stromal bed. And this is calculated with what we call the lenticular thickness index, which shouldn't be more than 28%, which is the relation between the lenticular thickness and the total corneal thickness. It shouldn't be more than 28%. The seventh recommendation is the cap thickness preferable to be not less than 100 micron, because the thinner, the more high-order aberrations are affected. The eighth recommendation is the optical zone. The larger the optical zones, the less the undercorrection. The smaller optical zone may increase the risk of refractive regression. This is in the refractive lenticular extraction surgery and in the regular LASIK surgery also. The larger the optical zone, the fewer the high order aberrations. The large optical zone is recommended if the corneal thickness is sufficient. 10th recommendation, the smaller optical zone, the smaller effect on the postoperative corneal biomechanical strength. The thinner the corneas or higher degrees of myopia, it's recommended to reduce the size of the optical zone to preserve the 280 microns residual stromal bed. Astigmatism correction. Refractive lenticular extraction surgery can correct up to 5 diopters of astigmatism. Correcting astigmatism with axis alignment and cyclotorsion give better results than without alignment. The decentration. The 14th recommendation is the centration. Location are the coaxially sighted corneal light reflex and the entrance of the pupil. So this coaxially central corneal light reflex should be regular centered with the and this gives better visual acuity, lower residual refractive error, and fewer induced high-order aberrations, particularly the common. 0.2 millimeter of decentration will not cause significant decrease in the post-operative visual acuity and quality. The decentration angle kappa should be very well respected, and there is impaired post-operative visual acuity with large angle kappa. Regarding the preoperative refraction, functional abnormalities like accommodation or binocular revision should be put in mind because they have a large effect on the postoperative results. Organic diseases, nystagmus, strabismus definitely decrease the results of the refractive lenticular extraction surgery. Accommodation is one of the most important factors affecting the prediction and the precision of refraction measurement. Cycloplegic refraction is a must for all LASIK patients. Regarding the nomograms, yes, there is a nomogram for patients regarding the spherical equivalent, the age, laterality, corneal curvature, diameter of the lenticule, biomechanical properties of the patient, the cap thickness and the center corneal thickness, and the residual stromal bed, and accommodation in the laser surgery. Regarding the agreed recommendations for how much to put from the refractive from the refraction of the patient is we have to add 10% overcorrected for patients with myopia from -3 to -7. Add 7% for patients with myopia between -1 and -3, and add 12% for patients with myopia over -7 diopters. For astigmatism, you have to add 10% or increase the nomogram values by 10% for the target cylindrical treatment. The complications. Intraoperative adverse complications should be avoided, and the main preventive measures to prevent difficult lenticular dissection, improper laser surgery, save the severe OBLs and black spots should be prevented and avoided. Lenticular management. The lenticule should be carefully identified and dissected. If the lenticule is adherent to the back of the cornea, magnify the microscope, use sharp inverted dissector to separate the lenticule from the back of the cornea, and don't forget the slit lamp in the microscope that it helps in visualization of the cap and the lenticule. And in cap perforations or tearing, the cornea must be tightly aligned and a bandage contact lens is recommended. In cases of suction loss, the patient should be educated to be calm and fix in the green light or whatever the light in front of him. Calming the patient, giving preoperative diazepam is helping to make the patients calm. The continuous communication with the patient and the head and eye position and supports to have a relaxed patient is mandatory for continuing the surgery. Conjunctival tissue trapping and excess water on the ocular surface and conjunctival sac should be avoided. In cases of suction loss, if the periphery less than 10% of the laser had been started, you can redock the and continue the procedure. But if the suction loss occurred more than 10% of the starting procedure or near the center, you have to reschedule the surgery, which is after a few hours as if nothing happened because the bubbles of the film to layers just separate the tissues and they do not cut through. So if you do not enter, it returns as it is. Black spots refer to points where the femtosecond laser fails to produce effective cutting action on the corneal tissue during the keratolenticular extraction surgery. Insufficient energy is a risk factor for black spots. In cases of black spots, they could be prevented by strict patient selection, clean and properly humidify the ocular surface. The suctioning and the patient interface should be in accordance together and avoid the repeated suctions. Small peripheral black spots you can continue, but large central black spots you have to stop and reschedule the surgery. Prevention of retained lenticular fragments. If this by preoperative good preparation of the laser energy, temperature, and humidity, which are mandatory factors to have a good laser energy. Retained lenticular tissues should be thoroughly identified and removed, especially when in the optical zone. Prevention of infections is mandatory by preoperative antimicrobial drugs. Treating the ocular surface disease is mandatory to decrease the postoperative dryness. Pathogens should be suspected as early as possible. And if there is severe infection, the incision should be enlarged and the removal of the tissues entrapped in the pocket is mandatory to decrease the amount of infection. The postoperative DLK is prevented by the careful examination of the external eye, and the operative eye should be cleaned, and disinfection methods and and treating the preoperative dry eye. Infection should be differentiated from inflammation. In case of inflammation, steroid rinsing of the pocket should be done. Causes prevention and treatment of principles of delayed visual recovery and poor visual acuity after KLEX surgery. It is recommended to know what are these causes of delayed visual recovery, which differs from individual to another individual and depends on the various intraoperative conditions, especially if there is a long time in or excessive manipulation, which usually induce early post-operative corneal edema and healing reaction. So the treatment principle depend on the patient from another patient, and the vision often improves gradually over time, which may reach up to 5 to 7 days after the surgery. And for residual post-operative refractive errors, enhancement surgery can be performed after 6 months of stable refraction. Early recommendation of ectasia is a must by continuous post-operative monitoring of the vision for all patients of the LASIK surgery. Visual decline and newly detected refractive errors should be noticed, and if there is very early changes in the posterior float with the pentacam, this should be treated with the cross-linking, and in selection of the patient, avoid corneas with abnormal morphology and eye rubbing, and take care of the changes of the posterior corneal elevation. Once it is noted there is a continuous posterior corneal elevation, very early cross-linking is recommended with rigid hard contact lens or whatever the contact lens to be put after the surgery. To sum up, these evidence-based recommendations for kerato-lenticular extraction surgeries in clinical practice are expected to improve the safety and effective application of KLEX procedures and achieve more satisfactory visual correction. And thank you so much.